Let me tell you something that most people sitting in their doctor's office right now will never hear. You go in, your blood pressure is high, maybe it's been creeping up for months, and your doctor hands you a prescription. You fill it, you take it every day, you feel like you are doing the right thing. And here is the part nobody tells you. For a significant number of people, that pill is quietly making things worse. Not because doctors are careless, not because medicine is broken, but because there is a gap between what the clinical research actually shows and what gets communicated in a 15-minute appointment. A 2018 analysis published in the Journal of the American Medical Association found that nearly 1 in 5 patients on common blood pressure medications experienced what researchers called a paradoxical pressure response, meaning their readings did not improve or in some cases went in the wrong direction. 1 in 5. That is not a rare side effect buried in a footnote. That is millions of Americans quietly wondering why their numbers are not getting better, assuming they just need a higher dose, getting that higher dose, and the cycle continues. So if you are taking blood pressure medication right now, or you love someone who is, stay with me, because what you are about to hear in the next 15 minutes could genuinely change how you manage this condition. And I promise you, the truth here is not scary, it is actually empowering. So let us start from the very beginning, because blood pressure is one of those things people think they understand but actually do not, and that misunderstanding is where the real danger lives. Blood pressure is simply the force your blood puts on the walls of your arteries as your heart pumps it through your body. When doctors say your reading is 120/80, they are measuring two things simultaneously. The top number, called systolic pressure, is the force when your heart beats and pushes blood out. The bottom number, called diastolic pressure, is the force when your heart rests between beats. Both numbers matter, but here is something most people do not know. Diastolic pressure, that bottom number, is often the more dangerous indicator in adults under 60, yet most mainstream conversations focus almost entirely on the top number. This creates a blind spot. You could have a systolic reading that looks acceptable while your diastolic is silently elevated, and your medication might be targeting the wrong problem entirely. Now here is where the conversation around blood pressure medication gets complicated and genuinely important. There are several major classes of blood pressure drugs. Beta blockers, ACE inhibitors, calcium channel blockers, ARBs, and diuretics are the most common. Each one works on a different mechanism in your body. Beta blockers slow your heart rate. ACE inhibitors relax your blood vessel walls. Diuretics push excess fluid out through your kidneys. The problem is that your body is not a simple machine. It is a deeply interconnected system of feedback loops, and when you disrupt one part of the system, other parts react, sometimes in ways that counteract the medication's intended purpose. This is called compensatory physiology, and it is the core reason why the same pill that works beautifully for your neighbor can actually destabilize your readings. Your genetics, your kidney function, your sodium sensitivity, your age, your hormonal balance, all of these factors determine how your body responds to any given medication. And the traditional model of prescribing often does not account for this level of individual variation. Let us talk specifically about one of the most commonly prescribed classes, beta blockers. Drugs like metoprolol, atenolol, and carvedilol are given to millions of Americans every year, not just for blood pressure, but for heart conditions, anxiety, and even migraines. They work by blocking the effects of adrenaline on your heart, slowing it down, reducing how hard it pumps. And for certain people, particularly those with heart failure, arrhythmias, or a history of heart attack, beta blockers are genuinely life-saving. There is no debate there. But when they are prescribed primarily for high blood pressure in otherwise healthy adults, the picture becomes more complicated. A landmark review published in the British Medical Journal evaluated data from over 90,000 patients and concluded that beta blockers were significantly less effective at reducing the risk of stroke compared to other blood pressure medications, and yet they were being prescribed at similar rates. The researchers noted that the widespread use of beta blockers for hypertension had become more of a habit than an evidence-based choice in many clinical settings. That is not a small thing. That is the kind of finding that should shift how millions of prescriptions are written, and yet change in medicine moves slowly. Now, there is another issue that is almost never discussed openly, and I want to spend a moment here because it affects a lot of people silently. Beta blockers and certain other blood pressure medications can cause a condition that sounds almost counterintuitive. Medication-induced fatigue that leads to reduced physical activity, which then raises blood pressure through a completely different pathway. Think about what happens when someone starts a medication that makes them feel tired, foggy, and low energy. They exercise less. They move less. Their metabolism slows slightly. Their body accumulates more fluid. Their stress response changes. And within weeks or months, the very disease they are trying to control worsens. Not because the medication failed chemically, but because the side effect profile created a downstream lifestyle cascade. Researchers at Stanford University identified this as one of the underappreciated contributors to what they called treatment-resistant hypertension, a condition where blood pressure stays high despite medication. And the uncomfortable truth is that in some of those cases, the resistance is partly driven by the treatment itself. But here's the part I really want you to understand, and this is where the conversation becomes genuinely useful. None of this means you should stop taking your medication. Please hear that clearly. Stopping blood pressure medication abruptly, especially beta blockers, can cause a dangerous rebound spike that is medically serious. What this means is that you have the right, and frankly the responsibility, to be an informed participant in your own care. There are specific questions that can change the entire direction of your treatment, and most people never ask them. The first question is this: based on my specific type of hypertension, which class of medication has the strongest evidence for people with my profile? This one question forces your doctor to individualize the conversation rather than apply a generic protocol. The second question is, can we measure my renin levels before choosing a medication? Renin is an enzyme your kidneys produce that plays a central role in blood pressure regulation. Some people have high renin hypertension and they respond much better to ACE inhibitors and ARBs. Others have low renin hypertension and respond better to calcium channel blockers or diuretics. A simple blood test can tell you which group you fall into. And yet, according to research published in the Journal of Hypertension, fewer than 15% of hypertension patients ever have their renin levels measured before a prescription is written. That is a 15% diagnostic rate for a test that could fundamentally change which medication you receive. The third question is, what non-pharmacological interventions, alongside medication, have strong enough evidence to potentially reduce my dose over time? Because that conversation, the one about reducing medication through lifestyle changes, is often not initiated unless you ask. Let us talk about something that the data on blood pressure management keeps revealing, and yet it remains dramatically underutilized in clinical practice. Dietary sodium reduction in people who are sodium sensitive, which is estimated to be about half the hypertensive population, can reduce systolic blood pressure by 8 to 14 millimeters of mercury. To put that in perspective, that is approximately equal to the effect of a single standard blood pressure medication. Not as a replacement for medication in severe cases, but as a meaningful adjunct that can allow lower doses, better control, and in some cases, a path toward reducing pharmacological dependence under medical supervision. But sodium sensitivity is not universal. And here is where it gets even more nuanced. If you are not sodium sensitive and you aggressively restrict salt, some research suggests you can actually activate the renin-angiotensin system, the very hormonal pathway that raises blood pressure, essentially making things worse through overcorrection. This is why blanket advice like just eat less salt misses the complexity of what is actually happening in each individual body. Now I want to bring up something that a lot of people in the 50-plus age group are experiencing but not connecting to their blood pressure. Sleep-disordered breathing, and specifically obstructive sleep apnea, is one of the most powerful drivers of treatment-resistant hypertension, and it is massively underdiagnosed. The American Heart Association estimates that roughly 30% of people with hypertension have sleep apnea as a contributing or primary cause. During an apnea episode, which is when your airway briefly closes and you stop breathing for a few seconds, your body floods with stress hormones, your heart rate spikes, your blood pressure surges, and this can happen dozens or even hundreds of times per night. If your blood pressure is difficult to control despite medication, and especially if you snore, feel tired during the day, or have been told you stop breathing in your sleep, getting a sleep study done is not optional. It is urgent. There are documented cases where treating sleep apnea alone brought blood pressure into the normal range without any medication changes. And yet, the conversation about sleep apnea is almost never part of the standard hypertension treatment discussion. Here's another piece of the puzzle that most people carrying a blood pressure prescription are completely unaware of. Certain over-the-counter medications and common supplements interact with blood pressure drugs in ways that can significantly undermine their effectiveness. Non-steroidal anti-inflammatory drugs, the category that includes ibuprofen and naproxen, which are sold under brand names like Advil and Aleve, are taken by millions of Americans casually and frequently for pain, inflammation, and headaches. What most people do not realize is that NSAIDs cause the kidneys to retain sodium and can elevate blood pressure significantly, sometimes blunting the effect of antihypertensive medications almost entirely. A person faithfully taking their blood pressure pill every morning and then taking ibuprofen 3 times a week for knee pain may be creating a pharmacological conflict that explains why their readings are persistently elevated. Decongestants like pseudoephedrine, found in common cold medicines, are another major culprit. They constrict blood vessels by design. That is how they reduce nasal congestion. And this same mechanism raises blood pressure in a way that directly works against whatever your medication is trying to do. Even licorice root, which sounds benign and is found in many herbal supplements and teas, contains a compound that raises blood pressure through a hormonal mechanism. These interactions are not exotic or rare. They are happening in millions of households right now, and they represent some of the most practical, immediately actionable information for anyone managing blood pressure. Let us shift to something equally important: the emotional and psychological dimension of blood pressure, because this is profoundly underestimated in clinical settings. Chronic psychological stress does not just make you feel tense. It activates your sympathetic nervous system, keeps your cortisol levels elevated, and creates a state of sustained physiological arousal that directly raises blood pressure over time. A study from University College London that tracked over 10,000 participants over several years found that people who reported chronic work stress had significantly higher rates of developing hypertension compared to those who did not. This is not about occasionally having a bad day. This is about the chronic, relentless, low-grade stress that many Americans experience as simply normal life. Financial pressure, caregiving responsibilities, social isolation, poor sleep, constant digital overstimulation. These are not soft lifestyle factors. They are physiological drivers that influence the same hormonal systems that your medication is trying to regulate. And no pill, regardless of how precisely targeted it is, can fully counteract a nervous system that is running in crisis mode day after day. This brings up a clinical approach that is gaining serious traction in cardiology and internal medicine, something called precision hypertension management. Instead of matching everyone to a standard first-line drug based on their reading alone, precision management uses a combination of biomarkers, including renin, aldosterone, kidney function markers, genetic variations in drug metabolism, and lifestyle factors to create a truly individualized treatment plan. Some major academic medical centers have already moved in this direction, and while it is not yet available in every family medicine practice, knowing that it exists means you can ask about it, seek out specialists who practice it, and advocate for a more personalized approach to your own care. The days of one-size-fits-all blood pressure management are coming to an end in evidence-based medicine. The question is just how quickly that change reaches the average patient. I also want to take a moment to talk about something called white coat hypertension, because research consistently shows it is more common than most people expect, and it is far more clinically significant than it sounds. White coat hypertension is when your blood pressure reads high in a medical setting but is actually normal in your everyday environment. It is caused by the anxiety and stress response that some people have in clinical settings, even when they are not consciously nervous. Studies estimate that somewhere between 15 and 30% of patients diagnosed with hypertension may actually have white coat hypertension, meaning they are being treated for a condition that only manifests in the doctor's office. The solution here is simple but underused: home blood pressure monitoring with a validated cuff, taking readings at different times of day over several weeks, and sharing that data with your doctor. The American Heart Association recommends home monitoring precisely because it gives a far more accurate picture of your true blood pressure pattern than a single in-office reading. And yet, a surprising number of people have been on blood pressure medication for years without ever doing consistent home monitoring. If that is you, this is worth discussing with your doctor immediately. Now, as we move toward wrapping this up, I want to make sure you walk away with something concrete and actionable, not just a lot of information that feels overwhelming. The core message here is not that blood pressure medication is bad. It is that blood pressure management is a nuanced, individualized process, and you are a full partner in it. Your medication may be exactly right for you. It may need to be adjusted, or there may be an unaddressed factor, whether it is sleep apnea, a drug interaction, medication-induced fatigue, chronic stress, or a dietary mismatch that is working against your progress without anyone realizing it. The most powerful thing you can do right now is have a more complete conversation with your healthcare provider. Bring your home monitoring data, ask about renin testing, review every supplement and over-the-counter medication you take, Discuss your sleep quality. Ask whether the class of medication you are on has the strongest evidence specifically for your type of hypertension. These are not aggressive or confrontational questions. They are the questions of an informed patient who is serious about getting well, and every good doctor will welcome them. And here's something I genuinely want to know from you. What has been your experience with blood pressure medication? Have you noticed that your numbers are not improving despite taking your medication consistently? Have you ever had a doctor discuss renin levels, medication timing, or drug interactions with you in any real depth? Or maybe you found something that made a meaningful difference, a lifestyle change, a different medication, a specialist conversation that changed everything. Drop it in the comments below. I read through them, and your experience could genuinely help someone else watching this video who is quietly frustrated and looking for answers. These conversations matter, and this community grows stronger when people share what they have actually lived through. If this video gave you something useful, share it with someone you care about who is managing high blood pressure, because there is a real chance they are carrying unanswered questions that no one has helped them ask yet.